leading to a significantly low body weight in the context of age, sex, developmental trajectory, and physical health. Significantly low weight is defined as weight that is less than minimally normal for children and adolescents and less than minimally expected for age. This is particularly relevant to the pediatric population because what you frequently see is a failure to grow, not necessarily weight loss. And then another core feature is the intense fear of gaining weight or becoming obese, or persistent behaviors that interfere with weight gain. So with pediatric populations, you may not see weight loss. What you'll see is failure to grow. The disturbance in the way in which one perceives their body and how significant body images and self-evaluation is unique to eating disorders, and a failure to recognize how serious the low body weight is. So what's different in DSM-5 for eating disorders, for anorexia nervosa specifically, is that the requirement of less than 85% of your ideal body weight is different. The other criteria is not that there's the absence of menses or the loss of menses was previously a criteria in DSM-5 is no longer a criteria. And then the recognition that there's an abnormality to your body weight is no longer a criteria for anorexia nervosa. Avoidant restricted food intake disorder, as I mentioned before, is new to DSM-5. It's an eating or feeding disturbance that manifests as an apparent lack of interest in eating or avoidance based on sensory elements and sensory characteristics of food, or concern about adverse consequences of eating. So many of you may have seen these kids in the context of they had a choking event and now they won't eat. What's significant about these children or young people is that their fear and aversion to consuming food is significant enough that it results in significant weight loss or other pretty significant medical problems. They experience significant nutritional deficiencies, and the eating disturbance interferes with their psychosocial functioning. Bulimia nervosa, the diagnostic criteria have not changed very much. What is different is that in bulimia nervosa, the requirement has been changed to episodes occurring once a week for 3 months. With bulimia, what's significant, just in terms of the criteria briefly, it's eating a significantly larger portion than normal food within a 2-hour period of time. What's important in the core elements of this disorder really is the sense of lack of control. With bulimia, unlike binge eating disorder, bulimia is followed by compensatory behaviors after the binge episode. So laxatives, diuretics, vomiting, excessive exercising, other ways of purging are a core feature. The frequency, at least once per week for 3 months, and of course, self-evaluation is influenced by body image. Binge eating disorder is a new addition. It's recurrent episodes of binge eating. Binge eating is often hard to quantify, but the diagnostic criteria requires one time each week for about 3 months that's not associated with compensatory behavior, which makes it different than bulimia. What are the episodes? The episodes are eating rapidly until they're uncomfortably full. Most of these episodes occur when the individual is not hungry. It typically occurs alone because the person is embarrassed and ashamed. And typically after the binge episode, individuals report feeling disgusted, depressed, or guilty or ashamed. One of the other key features is the person has to experience significant distress to meet the criteria for binge eating disorder. So what are the prevalence rates of these disorders? And why are they important? Well, they're not important because they affect large numbers of people, at least not right now. They're important because the mortality associated with pediatric eating disorders is higher than it is for any of the other disorders of childhood. Currently, the estimates for international prevalence rates suggest that for anorexia nervosa, lifetime rates are between about 2 to 4% for females and about 0.1% for males. Point prevalence rates are lower. For binge eating disorder, bulimia nervosa, the point prevalence rates are estimated to be about 0.5 to 0.6 for females. For binge eating disorder, prevalence rates are estimated to be at about 0.62. One of the reasons that it's been hard to get good data on prevalence is that across countries, across states, inconsistent criteria are used for assessment and for diagnosing these disorders. So what do we know based on US samples? North American populations tend to have much higher rates of eating disorders. What we know in the United States is that the median age of onset for anorexia, bulimia, and these other disorders tends to be quite young, usually about 12 years of age. But what's even more concerning is at the time these young people are diagnosed, they typically have other significant comorbidities. So about 97% of these youngsters that we're identifying with eating disorders have reported significant impairment in their day-to-day function. About 30% or more have expressed suicidal ideation. About 8% have made a suicide attempt. And of those, only about 2/3 actually seek out treatment. 25% seek out specialty treatment. In my community, where we actually have a large number of psychiatrists, it is still very difficult to find eating disorder specialists, which means a lot of the children actually go with no treatment or not evidence-based treatments. And the aggregate mortality in the US for eating for anorexia nervosa specifically is an average of about 6% per decade, which is significant. There's not many other things that children die from with mental health conditions at that rate. So I wanted to point out this study briefly to you. I mean, it was a Canadian study. It was very interesting because this study actually focused on children between the ages of 5 and 12. These were subjects recruited from a registry of rare diseases across the country, so there were about 161 kids identified for this study. What I found interesting about this study, specifically, were first of all, the high number of kids who were identified. These were kids identified with food avoidance, so they didn't necessarily carry a DSM diagnosis. What was striking is the number of kids who were actually worried about gaining weight or getting fat. So 70% of the kids in this sample were concerned about gaining weight. And these are kids between the ages of 5 and 12, so they haven't even reached adolescence yet. 70% were preoccupied with their weight. Over 50% felt that there was something wrong with their weight. So even though they were normal weight or underweight, they felt like their weight was normal. And then, of course, there are fairly high rates of comorbidity. About 1/3 of the kids, which is higher than you find in the population for most pediatric populations. The other thing that's not on this chart is that about more than 50% of these kids had experienced significant growth delay. So that even though they were normal height, they were low weight. And some of these children had not even reached their normal height, but they had not been identified for psychiatric treatment. Using the DSM-4 criteria, these kids would not have met the criteria for eating disorder. Using DSM-5 criteria, the majority of the children would have met the criteria for anorexia nervosa. So why is this important? Well, we used to think that if you feed these kids, they get back to normal, but that's actually not true. So we know that from adult and older adolescent studies that there's significant physical impact of malnutrition. So that when you look, these are images provided by Dr. Kara Fitzpatrick at Stanford. When you look at this is the normal brain, and this is the brain of someone who's been malnourished for a period of about a year. What you notice is shrinking of the brain tissue, expansion of the ventricles that are more dilated, with loss of nerve connections. What we see with children with eating disorders, we see significant cognitive changes at the time of assessment. We refer to it as an organic brain syndrome. It actually is an organic brain syndrome related to chronic malnutrition. The children have executive function deficits, slow thinking, they seem to get stuck. The perseveration that we see around their weight is not specific to their weight, but it's across multiple domains. They ruminate, they're obsessive, they have difficulties with basic decision making. Their distortions about weight and their body image are recalcitrant to traditional psychotherapeutic interventions. And at some point, for severely malnourished adolescents, the self becomes eclipsed by the eating disorder, so they no longer separate themselves from the illness. So why does this happen to some people and not other people? Well, eating disorders are classic biopsychosocial disorders. There are genetic influences. We know that based on monozygotic twin studies and family studies, where we notice that there are much higher rates of eating disorders among first-degree relatives of those affected by eating disorders. There's significant hypothalamic pituitary dysfunction as people starve. So commonly, people with eating disorders will present with hypothyroidism, other abnormalities. There are deficits in serotonin and dopamine, significant difficulties with executive function, which makes treatment very difficult. And then there's predisposing personality characteristics that make some people more susceptible, such as perfectionism, rigidity, a tendency to be obsessive. And then, of course, there's tremendous socio-cultural influences, which are major contributors to eating disorders. So, for example, in the United States, this is what we tell kids. We tell them that this is what their plate should look like. And it should have fruits, grains, vegetables, and protein. Low fat, where there's almost no fat in anyone's diet anymore. So when should you, as a psychiatrist or other provider taking care of a young person, become concerned about intentional weight loss in adolescence? It's an important question because in the United States, at least 80% of adolescent girls, by the time they're 12 years old, have had some diet of some sort. It's important to remember that many of the young people developing disorders were actually overweight when they started their diet. But signs to watch for are elusive weight loss goals. They lose 10, then they want to lose 10 more, then it becomes 20 more, and then it becomes endless. Falling off their weight or height curve, and we'll look at a few of those. Loss of periods, though not a diagnostic criteria, is a physical sign to be concerned about. Unhealthy weight loss practices, vomiting, diet pills, laxatives, or rapid weight loss or large fluctuations in weight. Physical signs and symptoms, I won't go through all of these, but the big ones are fatigue, cold intolerance, dizziness, early filling with meals, autonomic dysfunction, so that frequently you'll see kids presenting with orthostasis, changes in their blood pressure or changes in their heart rate, frequent stress fractures, loss of periods or menstrual irregularities, delayed puberty, and with type 1 diabetes, we're starting to see more young people who withhold their insulin, so it decreases their appetite and increases their capacity for weight loss. So unexplained elevations in hemoglobin A1C in an adolescent who was previously healthy should be concerning. The complications are numerous, they affect every organ system, and the initial evaluation is actually quite comprehensive. So that essentially for adolescents who have been engaged in disordered eating for some time, you'll see abnormalities across all these domains. I specifically would like to point out one thing that's relevant. We get DEXA scans for bone density for every adolescent who presents with anorexia. We used to believe that if we corrected the nutrition, then the bone density would develop to normal adult bone density. We know in many cases that's absolutely not true, speaking to the need for early detection and intervention. So what's the initial management of eating disorders? Interestingly, the best management of eating disorders occurs on an outpatient basis. The first line may seem sort of intuitive, empower the parents to take over feeding, but as I talk to you a little bit more about family-based treatment, you'll understand why that's really important in eating disorders treatment. It's important that you as the provider, and many of you in the room may feel like you'll never have to treat these disorders, but in industrialized nations, what we've come to appreciate is that for individuals who immigrate from a less industrialized nation to a more industrialized nation, their rates of eating disorders become the same. So each of us at some point will be faced with the need to recognize and intervene. When you start to work with patients with eating disorders, you need to set an initial goal weight based on prior growth curves, with the expectation that they will obtain at least 75% of what their ideal body weight should be. We provide structured meal plans in the office with every visit. When kids are malnourished, their calorie needs are significant, so we end up requiring that they consume 2 to 3 times the amount of normal calories that they typically consume because they're hypermetabolic. If you need to use supplement, limit discontinued physical activity. If they're on the soccer team or the tennis team, they can't do that anymore until they're gaining weight. We monitor their weights and their vitals. And refer to an eating disorder specialist if you can. But for young people presenting initially with eating disorders, it's perfectly appropriate for them to be managed by a team, a pediatrician, and their psychiatrist or psychologist. And if the patient refuses to eat and starts to lose weight, obviously refer them to emergency treatment. So criteria for hospital admission, less than 75% of ideal body weight, refusal to eat, low heart rates, orthostatic changes, hypothermia, low temperature, or any arrhythmia. But the treatment goals to keep in mind, and this is really important, is full physical recovery. So when you start eating disorders treatment, despite the fact that a young person might feel comfortable at a lower weight or their family might feel comfortable, the goal is to get that adolescent back to their ideal body weight. Is full physical recovery, full pubertal recovery, full cognitive recovery. And what does that look like? It means they attain a healthy weight, that their physical symptoms are gone, that they have full behavioral recovery, that you're not seeing disordered behavior, they have flexibility around their eating, and there's psychological recovery. They feel better about themselves, they start to have normal interpersonal relationships, and they abstain from weight loss behaviors. So medication management, I wish that worked. Food itself is the treatment for eating disorders, and there's no other successful treatment. Medications are not designed for malnourished brains. No medication treatment to date has been effective. However, there's a growing body of data that has demonstrated utility of Zyprexa for eating disordered individuals. Now, we all know Zyprexa can cause significant weight gain, which is a yay for eating disorders. The problem is they won't take it. We prescribe it for eating disordered adolescents or young people who have significant emotional dysregulation or behavioral dysregulation. So for those of you who have treated eating disorders, you know there's a propensity at times for people to become fairly aggressive when they're forced to eat. Or to complain of suicidal behavior, suicidal thinking. So basically, Zyprexa has been very effective in some of those populations as short-term treatment. So what actually works for eating disorders? The most evidence-based treatment is family-based treatment. It has the strongest evidence base for successful treatment of anorexia nervosa and bulimia nervosa in adolescents. Family-based treatments encourage parental control and management of eating disorders. There's no focus on why it happens. At the time that you're malnourished, we don't really care why it happened. The psychological underpinnings aren't going to make you start eating. Cognitive behavioral therapy and dialectical behavioral therapies have also been effective treatments for eating disorders, but those treatments are only effective in those who have the insight to recognize there's a problem. So if you're starved and you think that your weight at the 50th percentile is normal, cognitive behavioral therapy is not going to change that. So cognitive behavioral therapy has substantial evidence for treatment of adults with bulimia nervosa. When we compared family-based treatment with cognitive behavioral therapy for bulimia, what we found in 12 months is that we had equal benefit. But what we noticed about family-based treatment is that we had a significant reduction in binging and purging behavior by 6 months. So that one could use family-based treatment or cognitive behavioral therapy for bulimia, but if you need a quick response, family-based treatment will be more effective than cognitive behavioral therapy in 6 months. So we use, at the Children's Hospital, we use a family systems approach to the treatment of pediatric anorexia and bulimia. I'm going to talk a little bit about that. Family-based treatment, as like I said, this has the strongest evidence base for effectiveness for eating disorders. Back in the old days, before my time, the approach was really very individual focused. The message was that teenagers should control their eating. This is completely opposite the approach with the family-based treatment. The outcomes at that time should only about a third of young people actually reach remission with individual psychotherapy. With family-based treatment, 2/3 of young people in 12 months will reach full remission. So it's an outpatient intervention designed to restore weight and put the adolescent back on track. So the goal is, within 6 months to a year, that adolescent will be doing the things they were doing before. It's appropriate for those who have maintained greater than 75% of their body weight when medically stable. Frequently, we use a brief hospitalization for medical stabilization. It's a medical hospitalization for 1 to 2 weeks because there's no evidence to support that inpatient psychiatric treatment for eating disorders is any more effective than outpatient treatment. Some of the factors that may impact successful treatment for families with high levels of discord or serious fighting between the parents or severe parental psychopathology is a barrier to outpatient treatment. And family-based treatment works best for children who haven't been sick that long. So that if kids have been sick for 3 years, the rate of response to family-based treatment will be less. And we believe that family-based treatment works so effectively because the mechanism of action is parent-facilitated exposure to eating. And we believe when children are malnourished, their parents actually know what's best in terms of what they should be eating, their care.
5 minutes.
Yes. Thank you. So just in terms of factors that impact potential outcomes for family-based treatment, some factors that decrease your prognosis for successful outcomes are extreme obsessionality as a characteristic of the patient, single parent or divorced parents,